I'm the president of the Community Health Nurses of Canada. I would love to welcome everyone to our second webinar in this series. It's the Community Health Nurses of Canada Professional Development Webinar Series. We are happy to have Dawn Tisdale back with us this morning. The first session was on April 10th. If you weren't able to attend that session on Easter Monday, no worries. It's not a prerequisite for being here today. The topic today is adopting Indigenous cultural safety, humility, and anti-racism into community health nursing. I am calling in from Gibsons this morning, my home, which is close to Vancouver. I would like to acknowledge with gratitude, the traditional territory of the Musqueam, Squamish, and Tsleil-Waututh peoples. If people want to acknowledge the traditional territory upon which you're calling in today, please feel free to use the chat. I'm sorry that we don't have enough time to do a round to acknowledge every traditional territory that you're calling in today. I also want to acknowledge recently on April 10th, it was the second Indigenous Nurses Day. And I want to acknowledge the key role of First Nations, Métis, and Inuit nurses helping us move towards reconciliation and culturally safe care environments. We do appreciate the partnership in ensuring equitable healthcare for Indigenous people, not only in this diverse province of British Columbia, but all other provinces and territories in Canada. This webinar series was generously sponsored by the First Nations Health Authority, and I really want to say thank you to FNHA for their financial support and collegial support in helping us put on these two webinars and being able to have Dawn with us this morning. Lastly, I want to also acknowledge National Nursing Week, May 8th to the 14th. The theme this year is Our Nurses and Our Future. And that theme showcases the many diverse roles and the changing roles that community health nurses play in a patient, client, community resident, family in that healthcare journey. Certainly, the pandemic brought to light the courage and commitment that all nurses in Canada work under every day and shows the important role that nurses play in the community, and not only community health nurses. Our organization has about 339 members in Canada, and we have 10 active standing committees with many community health nurses sitting on those committees. But I just want to extend my gratitude to all of you who are attending today, who may not be working in the domain of community health nursing. CHNC, we just very briefly, we have three objectives. I've just put them up. We're trying to advance the health of people in Canada. We want to strengthen our organization as the center of excellence in community health nursing and continue to build an effective organization. I now have the privilege of introducing Dawn, our guest speaker today. Dawn is a registered nurse of Mi'kmaq and European ancestry and is the Indigenous Senior Professional Practice Lead here in BC at BC Children and Women's Hospitals in a program called the Indigenous Health Program. Dawn, you're responsible for organizational Indigenous cultural safety policy, innovation, education, and research with a focus on children and women's health. Dawn has leadership experience in nursing and healthcare policy, which is focused on supporting the rights of an Indigenous-led healthcare to create cultural safe systems. We were talking to Dawn this morning. Dawn also led the Sanya's Indigenous Cultural Safety Training Program, which is a course in BC, but I also think that course has trickled east to Ontario. And Dawn also served on the Association of Registered Nurses of BC as a professional development lead. Dawn's healthcare background began in community support as an RN in medicine, palliative care, and health policy. Dawn, I think I will stop there and stop talking and turn it over to you to start today's webinar series. Just to say, Barb, who is the treasurer of CHNC, and Karen Curry, who is the president-elect, will monitor the chat today to support you, Dawn. And I know that there'll be a few pauses and opportunity to stop, and Barb and Karen will read out some of the questions that have come in through the chat. So thank you to everyone, and turning it over to you, Dawn.
Thanks, Donna, and thanks, team. Good morning, everyone. Oh, it's so exciting to see all the beautiful territories in which folks are joining in from. Thanks for adding that in the chat. And just to follow proper protocol, just do an intro for myself as well. So I am Dawn Tisdale, and I just by way of introductions for my ancestry. So on my father's side, white settler Ukrainian, and on my mother's side, French Irish white settler and Acadian. And then my grandmother Florence Roy was born in Bad River and is of Mi'kmaq ancestry and from Wabanaki Nation, which is colonially known as Bathurst, New Brunswick. And I grew up on Mohawk territory, colonially known as Montreal, and I'm currently an uninvited guest here on the occupied and unceded territories of the Musqueam, Squamish, Tsleil-Waututh, and Stolo Nations. Very grateful to be here. It's pretty hot in BC today, so I have my fan. I just turned it down a notch, but is it if it's cumbersome at all, I will turn it off completely. But can folks hear me clearly? Great. Okay. And it'll take a little bit of the heat off. I'm going to share my screen. Slide. Oh, went too far. How is that looking?
It looks great.
Looks good, Dawn.
Oh my gosh, I don't have any wood. I'm surrounded by plastic, but it all works. How wonderful. I just wanted to say too, just when you were talking about the Community Health Nurses Association, I don't know if I ever mentioned this to you, Donna, or team, but quite a few years ago now, I was the president for the Canadian Nursing Students Association. And your association was one of the first ones to, and it was that year as well, that you had adopted a nursing student onto your board in voting capacity and a whole bunch of other very important supports, and a whole bunch of other associations followed suit after that. So that was just such a tremendous, I guess, one can't always know the impact that has, but I clearly remember that AGM for our nursing association, and what a celebration and excitement it was when our community health nursing representative had shared just how lovingly supportive and but respectful and really recognizing the importance of student nursing and bringing us up and having that representation and voice in decision-making capacity. So just a kudos from years ago of what a wonderful association that you have and what a model it is. So happy Nursing Week, everyone. So today's conversation will focus more on nursing specifically. Not that the first session didn't, but we really looked at a lot of the guiding policies, Indigenous-led activism, really the contemporary harms that exist in ongoing ways within our healthcare system, and what is we just started to look at what the role of nursing is and embedded throughout. But this part of the session now uses that as a way to inform how this guides nursing, both as a profession, as a discipline, and then for us as individuals, and how that works together to disrupt these harms. So we ended last week on a quote from my colleague from the BC CDC, not a nurse, but a nurse at heart, Harlan Pruden. And he said it really hit me when he said this once during mentorship with me, was, does the remedy match the harm? And I think I carry this in my heart when I look at any of the actions in which we're implementing to disrupt systemic anti-Indigenous racism and implement cultural safety. And when we examine everything that we covered last time and the depths of that harm and how that legacy of harm translates today when Indigenous people are accessing services, but also how those are still embedded within many of the structures that we exist. And we'll talk more today too about how even nursing is embedded in a colonial structure that we are complicit in, and also actively working to dismantle, and the tension that exists within that dynamic. And he said, again, not a nurse, but he said something to the effect, I don't know if he used it, I can't remember if he used like the analogy of a broken arm or whatever, but someone comes in seeking care, has a broken arm. Are you handing them a Band-Aid, or are you, does the remedy match the harm? Are you giving them the proper resources and supports to heal and remedy the harms that have happened? And I would, I'll leave it to everyone to ponder and for us to think about this, carrying this forward. But this is really a North Star point for me, again, and a lens in which I try to analyze every action that I do personally moving forward, but also the organizations that I'm a part of that I hold to account. So despite the overwhelming body of evidence that was presented, I would argue that the responses from nursing organizations, and so just looking again at the three pillars of nursing, so the regulators, the unions, and the associations, and how together they have or have not worked to address systemic anti-Indigenous racism, and who's leading that work, who's leading that canoe, as one of my elders would say for an analogy. And I think it's really important in the canoe analogy that we're all paddling together, that we have very clear understanding of what our objectives are to address these harms and how they all work really at different points, either upstream, downstream, within the healthcare system. And I think nursing has put a lot of emphasis right now within education, and that is critical, right? Like nursing students are being introduced to these concepts. Many universities across the country are taking really good critical looks at how to take an anti-racism lens and also to shed light on the colonial history. I do think, and we'll talk a little bit more as we go along today, and something for us to think about. And please, I know it's so hard on Zoom, but it's so important too that we have like fulsome conversations, because we learn together collaboratively, right? But how that shows up in practice, right? And so I think again, one of the discourses is that nursing is trying to disrupt harms within the healthcare system. So it's looking at those issues and the harms as not as wrong, as a problem to be addressed and that we want to be in support of, but there still is an arm's length often in how that is conceptualized versus how nursing as a system with its colonial roots embedded within this system has participated to get us to the point where we are today, but also in an ongoing way. And that, I think, is an area, it's the next iteration. That's the area we need to lean into now to really uncover what that is and what that looks like. So one of the things that I think is super key for nursing is for us to champion cultural safety. And there's a whole bunch of reasons why I feel strongly about this. But the number one reason being is that it is a nursing concept. It's an Indigenous nursing concept. Its roots are from Maori nurses, colonially known as New Zealand, and it was nursing also that introduced it within the Canadian landscape. And I know it can vary from province to province. I'd be curious to hear, in the chat, how does your health authority, does your organization, does your team talk about, let's talk about like broader systemic anti-Indigenous racism as an introduction and wanting to disrupt that through cultural safety. So within British Columbia, certainly it is been very well adopted into all levels of language within the healthcare system, and all of our regulatory bodies now have that mandate. It's mandated through the Ministry of Health, and then each regulatory body now has a practice standard within the province. And I know that work is being done and introduced in other provinces. We also, and we covered this last time, had a very damning report that came out in British Columbia recently in the last 3 years, the In Plain Sight report. And that also, again, really reintroduced cultural safety, but in framing it more as anti-racism work, which was its original intent when Maori nurses brought it to, the broader political landscape. So I need to just move. It's funny with Zoom, you got like the all the pieces that are covering some of the screen here, and I don't want to accidentally shut anything off. So I want to give ode, one, because it's National Nursing Week, two, because what a tremendous nurse leader, and what did one of my colleagues mentioned, thought leader, described her as a thought leader the other day, and I couldn't agree more. So community nurse, actually, working in labor and delivery, but from my understanding, just the way also, and because of, I think, her focus on indigeneity and her indigeneity and community, worked a lot in community. And Dr. Ramsden saw a lot of harm in care, and she knew that nurses needed to lead that work to disrupt that harm, and that nursing could lead that change, and that the healthcare system needed to do better. So this was early 90s. She went back to school, became an educator, a scholar, a fierce activist. Developed the concept, again, late 80s, early 90s, due to her experiences in care. And again, I just really think, I'm just doing all the shout outs for Nursing Week, but this is why nursing is so critical, that nursing is involved in policy and bigger political action, because we are the ones who see we're the biggest health profession in direct care that has our finger on the pulse. So really important to use what Dr. Ramsden did as an example in how that then can play out to affect systemic change. And I mean, really, her work has impacted Indigenous healthcare globally in so many ways. the concept was met with huge resistance. Sometimes in my earlier scholarship days, I was reading her dissertation and her work when I was trying to better understand cultural safety. And I remember erroneously being quite critical, being like, why the heck did she call it cultural safety? Because people automatically think culture, right? They think that this is about often one of the misconceptions about the concept is that it's based on, okay, how do I know about a person's culture and relate to them? It's more like cultural awareness, cultural sensitivity. Folks get it mixed up in that. And those are important concepts, but we also know now, based on, really a lot of Dr. Ramsden's research, but also critical race theorists and scholars in this work, that knowing about a person's culture can be important in care, but that does not disrupt systemic racism, right? That doesn't necessarily also address, personal biases or how that plays out within broader systems. So similarly to, I think of Cindy Blackstock within Canada, and just the violence and vitriol that she faced. I think Dr. Ramsden is, our version of Cindy Blackstock within New Zealand. She was met with death threats. She had just a whole bunch of violence thrown her way to really damper, which again shows, I think, too, especially at a time, and we think, oh my gosh, the late 80s, right? At a time when, folks were denying that racism even existed, or that, white supremacy even is embedded in what that resistance, how that resistance played out. She couldn't talk about those things. Oh, I digress. This is where I was going off on a tangent. At first I was like, why did she call it cultural safety? That's so confusing for everybody. Call it anti-racism, call it what you were doing. But I think part of it, further writings from her colleagues afterwards had noted that it was a way to introduce it, I think, in a way that was palatable, to introduce these concepts, but in a way that wasn't jarring for folks at the time. And it really also shows how far we've come in our discourse now, and how we can name it in a different way. I mean, really, 5 to 10 years ago, if I was doing a lecture or talking about cultural safety, I very rarely said racism, and was discouraged to do it because it evoked such strong emotions in people and resistance. Like, people just checked out of conversations. And how wonderful and important and exciting it is that, again, and I think of how grateful I am to Dr. Ramsden that, I stand on the shoulders of these Indigenous matriarch nurses, right? Where I can now carry that work forward. Dr. Ramsden has since passed away, but how now this next generation too can carry this work forward because of the advocacy work that and the foundation that they laid for us. And I know that I'm sure Dr. Ramsden would talk about how she was held up and the work that was done before her. So it's really, again, incumbent upon us to, I feel, a huge professional responsibility to, again, just keep pushing this work forward. And I hope that, in 10, 20 years, someone's looking back on these conversations and being like, oh my gosh, that was not radical enough, and that we get to the place that we're all working towards. So New Zealand adopted it within 1992. ICN, so the International Council of Nurses, adopted the concept in 1995, and then it was brought within the Canadian landscape in the early 2000s, again by nurses, and a specific group of nurse scholars. So again, just showing, and I think, I always bring this up when we're talking about this work, and especially when I'm in policy spaces, I, make a note, I keep my registration up to date. I always say that I'm a nurse, because I think one of our biggest challenges as nurses is sometimes recognizing our own power and the impact that we have. And all again, for ourselves as a gendered profession, how we are also oppressed within that system, which also complicates matter. Like, we are both oppressive and oppressed, and we deal with that tension a lot. But I think advocating and being really clear about the importance and role, I mean, if not now, especially in current political climate for nursing, that we be really clear about what we bring to this work. So cultural safety, again, at its core, was to examine power relationships between health professionals and the patients that they served. Its intention was really safety from violence, anti-Indigenous racism, harms, colonial agendas, all of these pieces, to reduce the risk and promote the health and well-being of Indigenous people. And one of the other key pieces within, again, the New Zealand context was also about sovereignty. And cultural safety became such a critical tool within broader political movements, even outside of healthcare, that it's adopted and embedded within all levels of legislation within New Zealand. As a core concept based on sovereignty and the rights of Indigenous people to have access, and within the context of health, to safe, equitable care, full stop, right? And it took decades for New Zealand to get to that place. And there is, of course, ongoing, resistance and challenges, but the work that they've done is very critical and a good model. And also, I get asked a lot, why can't we do that within the Canadian landscape? And one of the important things to recognize too, for Canada in particular, is that we are not a homogeneous group in terms of our Indigenous populations. So like the Maori people of within New Zealand are, and that makes it just a lot, dare I say, easier to move that work forward, where we have to honor different, many, hundreds of nations within the context of Canada, and, non-treaty, treaty. We have the Indian Act, they don't. We have a whole slew of challenges related to that. But it's important to know what that context is for Canada, and then how we need to move this forward in different ways. So the focus of ICS. So I often say ICS, so Indigenous cultural safety, because cultural safety has been co-opted in many ways because it's such a great concept, right? I think that the idea of treating people in a safe, equitable way when accessing care applies to anyone, right? But in the unintentional erasure of the Indigenous aspect of that concept, it loses really its original intention that Dr. Ramsden was doing. So I'm a purist in that way. I think that it is really important as a concept that it stay grounded in her original intention. And there are lots of really important social justice, equity lenses that we can apply that support many different marginalized or targeted populations. But for cultural safety, really, again, it is full of concepts of decolonization, sovereignty, anti-racism, health equity, obviously, Indigenous self-determination. So again, that rights-based lens is at its core and is critical in this next iteration of how we conceptualize Indigenous rights within healthcare settings. And then power relationships. It was really focused on hegemony. It was focused on, that the nurse held all the power, and within that colonial system, and did not, I don't want to say never, obviously, but like in broader speaking, systemically, held that decision-making power in terms of what healthcare and what healthy living looked like. And then that reflexivity piece of that cultural humility, recognizing that, colonial Western white ways of being are not the only way, and that they don't exist in that supremacy model, that, that Eurocentrism is the only way to be within healthcare. And then very much action-based as well. So how do we carry this work forward? Her intention and goal wasn't that this, concept just float around and sit on the shelf, or, inform, scholarship and research, but that this was intended to be on the ground work that all of us adopt within practice. So what's the role of nursing in promoting Indigenous cultural safety and health policies? I love this quote from Dr. Ramsden. Again, I get teary-eyed, and it's just like nursing week. I'm just like, so I love our profession so much and feel so empowered by our collective work and how we move this work forward. But she said there are three kinds of people: those who make things happen, those who watch things happen, and those who never know what hit them. Let nurses be in the first category. And I truly believe in every fiber of my being that nurses are the ones. We are the folks that are the doing of the work within the healthcare system. Again, it's why we know, did I just quote CNA? Nurses know, because we're at that really important point of care, and we're embedded in every aspect, not only within the healthcare system, broadly speaking, but in all social sectors. I mean, you're hard pressed not to find a nurse, right? And so how do we, as this tremendously powerful collective, disrupt anti-Indigenous racism within the healthcare system? And how do community health nurses within their scope of practice disrupt that and embed cultural safety at all levels? So now just wanting to kind of unpack how the challenge and the tension that nurses face as complicit, and also fighting against systemic issues, and in this context, systemic anti-Indigenous racism. But one thing I think, again, we need to stop and really celebrate and recognize our strengths in, no profession's more badass than nursing. We have done such tremendous advocacy historically for the women's rights movement. It has been radical. It is the foundation of our society in many ways, and often very under-recognized, again, because predominantly women move this work forward. And I think that gendered piece really not only impacts how the healthcare system and others see us at times, but sometimes too how we have embodied that oppression ourselves, and sometimes don't even see how we are engaging it and not leaning into our own power and strength, and that really important strength that we have to move the needle forward in terms of, and again, in this context, anti-Indigenous racism, but within healthcare broadly. So keeping that at the forefront of our minds is critical. Knowing that cultural safety, again, is a nursing concept, how we and not in the power over / nefarious aspects of leadership, but how do we act as champions in this work to keep moving this work forward? And if if it's not nurses, then I don't know who it is. And so really a call to action. So yes, again, nursing is at the forefront of all of these really tremendous political social movements. We know that strength and knowledge, expertise, and heart-centered leadership is what has made us so great. You know, always voted the #1 trusted profession. All of those accolades and recognition. And we're also in this tension of being complicit within colonial harms. And so this is where I think that next iteration and what the Truth and Reconciliation was asking everybody to do was to really lean in before that reconciliation piece, to lean into the truth. So what is our truth within the Canadian state, within the harms and that legacy? And if we can't look at it, if we can't examine where that has existed for ourselves, we're not going to be able to deal with it and address it. And you know, when we look at the distrust that many Indigenous people face when accessing or unwilling to access care, it is because of these colonial legacies that exist. And I mean, we could go back really as far as nursing in its most recent form has existed, was very much co-opted by white Eurocentrism. And I just really want to just pause too and recognize that these conversations are hard, right? Because I never want it to come across that, again, I really hope that I've expressed how much I love and care about our profession. And one of the reasons why I think it's important to address where we have and are complicit within these harms is because of loving accountability, and because I care about our profession, and because I care about how we can move the work forward. And also that none of this exists without context, right? Like when I'm talking about biomedical supremacy or nursing's whiteness or white supremacy, it isn't to say we're not talking about like skin melanin, right? Like we're not talking about color specifically. We're talking about how broader systems of racism have guided some of the work and institutions and organizations and professions that we work in, and medicine was one of them. I think, and again, thinking about how nursing has both been harmed and been harmful in the system. I think nursing has been co-opted too. So I was reading, I love history, and was reading about I was reading some historical nursing literature from the States, and reading some of those first write-ups for when physicians were creating hospitals. And there's like a few lines in there that are explicitly saying that nursing is becoming too powerful in community, because it was nursing doing all of that care work, right? When like medicine was still using leeches, and it was like, how do we disrupt that really women's work and that care, and bring it within the institution? And how do we have control within that institution? And very clear language, how do we make nurses must be subservient to the physician. So within that system, right, and I think for nursing trying to gain power, we know again from the research, oppressed people then oppress as well in that scarcity model. And so nurses from point of contact were used as agents for colonization. The two main bodies within Canada that that were at the forefront of colonization was government and using healthcare as a tactic, and the church. And when we look at, the original nurses coming from Europe, it was, white nurse missionaries that were really disseminating and using healthcare and schools and education. And a lot of nurses were running Indigenous residential schools as a way to assimilate. And when, genocide wasn't, a possibility based on population, then the primary goal was assimilation. And so, when we look at the impact within Indian residential schools and all of the major health systemic issues that we're facing today, so Indian residential schools, Indian hospitals that worked really closely with Indian residential schools. And, it was they were at their height during TB, and it was coined that Indigenous people, there was like an Indian TB, and it was dirtier and more virulent than regular TB. So they had created Indian hospitals. And while there were very established Indian hospitals that were mostly nurse run, lots of folks that were not regulated, the same standards of practice for Indian hospitals versus non-Indian hospitals had completely different regulations. I really encourage everybody, if you haven't done a lot of reading, because I know I wasn't taught in nursing school, and this is really only starting to gain some traction within Canadian consciousness about the impacts and what Indian hospitals were, to read Lux's book, Separate Beds, but also to look, there's some really good lectures that have been recorded around just the experimentations that were done as well. And again, how, because these went well into the 60s, 70s, and how dentistry and nutritionists used Indian hospitals for experimentations. And when we look at some of the ongoing health related issues, and you might see this certainly in care, in direct care, as community nurses, is the nutritional impact. So withholding certain nutrients and seeing, all the experimentations that went along with that. And then dentistry as well, and different, and those, are the two that have come forward. And again, when we look at the TRC and leaning into the truth, I think those two professions have, particular scholars and advocates within them that have really done a deep dive, and which is so important. Because it explains why people do not, would rather suffer and even potentially die than go into an emergency room at this point. Because when this has been your experience within hospitals, you are not allowed to leave against medical advice. And some people were kept there for years against their will, long after their original, health concern was addressed or not addressed, and just atrocious harms that are just at the beginnings, I think, of coming to light in a more fulsome way. And the legacy of nursing within these institutions obviously is very real, that we also need to contend with and work to heal and remedy that harm that has been created. And again, it requires all of us to think and work together to figure out what that's going to look like. The other, so another key area, so child apprehension, back when community nursing was more prominent, and we were less institutionalized, particularly around labor and delivery, there was very intentional legislation that was done at the hands of nursing to apprehend Indigenous children and move them into white families for the purely assimilation processes. We had ads in the CNA magazine for, that were prominent everywhere within society, but, to buy an Indian child for, a few dollars. And again, I cannot stress enough when we zoom out and think about where these points have happened historically, that these survivors are accessing care today, and that the 60 Scoop survivors, and again, I would, supportively critique that the 60 Scoop also makes us think that these harms and this mass apprehension was solely focused on the 60s, but Indigenous children are grossly overrepresented in child welfare, child care today. And many Indigenous scholars and advocates, liken that to a continuation of the residential school system. And so back again, I think to the piece of, does the remedy match the harm? We're seeing, so even if we were to conceptualize this apprehension because of the disruption of a generation of folks that did not have the love and care of their parents because they were in residential schools being abused, who now are parents within the system, and that our response as within a colonial state is to apprehend those kids. I mean, that is just so tragic and violent, right? And again, what are we doing, and what is nursing doing to pinpoint that harm, recognize it, acknowledge it, and say we need to do things in a different way, and be a part of that action. And then another, I think, key area as well where nursing has, been complicit within a broader system is for sterilization. And, I was doing, developing some tools and educational resources for women's and children's. And I didn't even realize, there's so much that is hidden from all of us that grew up within Canada about where some of these harms come from. But I didn't realize how explicit within legislation, forced sterilization, eugenics was, and how, again, very deliberately it targeted Indigenous women specifically. And, there's current, a lot of important activism and work being done in class action lawsuits right now that will guide that work going forward. But again, I encourage all of us as nurses to be aware and in the know of how that is happening. Similarly, for sterilization apprehension, birth alerts in BC, which was a formalized process, only ended in 2019. So to also contextualize these things, and I think this is one of the pieces that, is a part of that insidious denial that we do, is to frame these harms as having happened in the past. And that just simply isn't the case. Like, yes, and that harm shows up today in a whole bunch of different ways and is actually happening in real time as well right now. I think that was, I feel like I'm forgetting one last piece, but I think that was that piece. Should I pause? Are there any questions? I see that the number's going up, but I don't see the chat.
Thanks, Dawn. There's a couple of comments, and then there's a couple of questions in the chat, and I can just read them out. I'll read the comments first. So they're definitely, we love the content, the quotes that have been put out. I just tweeted the quote that you had mentioned from in terms of nurses being part of taking action. So I just put that out there. And there's comments about language being used within nursing education and nursing in general. Patricia King made a comment that said, in teaching students, I noticed this past week how nurses can hinder these key features of creating ICS and enact power inappropriately and create inequitable environments with ease, working to help nurses of the future to be so mindful of their verbal and nonverbal language is very important. And yeah, just more comments about the quotes that you've been using, that we'll use these for sure. I know I'll use them in nursing education too. And there's a question, there's one comment that was sent to me about Florence Nightingale. I'm not sure if you have any comments about Florence Nightingale at all. I know it's Nurses Week this week, but in terms of the content that you talk about with Indigenous cultural safety.
Yes, so controversial. And again, thanks for raising it. And that actually was, I knew I was forgetting one point, and it was actually related. I went into some of the systemic examples where nursing has been complicit, but I forgot to go back to, so just I'll pause that answer for a second, or that conversation, just to say, yes, so back to, physicians being like, nurses will be subservient, we're going to create hospitals, let's get them out of community. So did nursing, right? And I think, obviously, we can go over the importance of being a regulated profession and having, a formalization of nursing and what that means, obviously, but also that, how we understand nursing often in a white settler society is that, nursing began with Florence Nightingale. And we know that nursing, and okay, so even just from an indigeneity lens, healers and matriarchs with this like incredible in-depth knowledge existed long before nursing was coined as a phrase, right? Or as a concept, or as a profession. That is so interesting to look at, even in terms of Indigenous rights. And this has been on my mind of late. I recently heard a Musqueam elder, which is one of the nations within Vancouver. And, he was talking about how, not uncommon on the coast for folks to live into their centennial year, and the medicinal and holistic approaches to health that led to that longevity. Again, when in a biomedical sense at the time, if we're just to compare timelines, where that wasn't the case. And, there are healers and, from, I'm just going to use again, maybe a colonial term, but nursing existed very much within those systems, in the essence of what nursing is, from like an ontological sense, right? So, and now we look and we've got the United Declarations on the Rights of Indigenous People that says in Canada that Indigenous people have the rights to practice their own medicines and health and healing practices. That's very broad. That's wonderful. And how does that translate into practice, right? Because, within regulation, which again, we know is critical and important, but there is a tension between that then. And, if a healer on Musqueam Nation wants to open shop and, practice and deliver and sell or whatever those medicines, that is in violation within certain standards of our system. And I'm just using that as an example to share just how, the systems can be in opposition of each other, right? So like, we're talking about recruitment and retention for Indigenous nurses, but the very rigid colonial guidelines within nursing that, some are obviously incredibly valuable, really important. And, you know, some are made up and some are very steeped in a white, Western way of being that is not in alignment with Indigenous health and healing practices. What are we doing as a profession to bridge that, right? How can Indigenous nursing and Indigenous ways of knowing and being be adopted within this current rigidity of the system? And again, I think that's what our generation needs to work on and do, and that's that next step. So we have that now. It's a very exciting guiding policy to lead us forward, to say Indigenous people have the rights to this. As a nation, we have to honor that right. But now we're in like the figuring out the how, and recognizing again that that is how white supremacy shows up within nursing. It's systemically, always like systemically, right? Where it's that saying like, but this is how we're going to do nursing. We have to say that we're going to look at doing it a different way. And again, you know, I can't help but, you know, just want to hit my head against a brick wall sometimes when, you know, biomedicine just preaches how, you know, incredible it is. And yes, oh my God, I just had umbilical hernia surgery. Yay, biomedicine, right? Like we want that. And when we're looking at population health and holistic health and healing practices, biomedicine does not have it going on, you know, and it comparatively, but that supremacy blinds us, I think, a lot of the times to think about, you know, where our current issues are, and then how we do need to do things differently. So sorry, back to Florence. I went on a tangent again. Yes, so I can only speak for myself, and you know, I hold space for the many different opinions about Florence Nightingale. And I think what comes to my mind is what one of my elders and mentors has taught me, which is two truths can exist. And I think that I mean, Florence is the case study, right? Like she is a woman, she's a privileged white woman, but she's a woman at a time when, you know, the patriarchy is reigning supreme, and is the first epidemiologist to, you know, really recognize and implement standards of practice and care. Again, beautiful example of nursing, right? Where like everybody was like, oh, why is everybody dying? And then the nurse is like, because all of this, because at that point of care, right? So again, the case study. And was also very much entrenched in the white supremacy colonial ideas of it at the time, had lots of racist rhetoric that were very problematic, and an agenda of colonization. And, you know, I think there's lots of ways as a society for us to hold space for the tensions that exist. And I think a lot of times we live in dichotomies, like that someone is, you know, all bad or all good or right or wrong. And that's also not real or true. And I think I have seen, you know, some of my colleagues who have written out against, you know, Florence Nightingale met with so much vitriol, which I think, again, is telling as well as to, like, my question is where's that coming from, right? Like, you know, we can, you know, honor and recognize nursing and its origins, while also holding space for the truth. I mean, really, that's what the conversation today is about. Again, that's why I'm saying it's the case study, right? It's that, you know, nursing isn't good or bad. It's that we exist within a complex system, and we have to play to our strengths, and we have to recognize our agency and what we're capable of doing, as did Florence at the time, and examine where we're contributing to harm and address that harm. And, you know, Florence, I mean, I don't know her history enough to know if she began that work, whether she did or not. But then it's our job now to do that. And we use that as an example, and we use that as fuel moving forward, to change that narrative and recognize that's our legacy, and what do we need to do now moving forward. I don't know if that was helpful, or if anybody wants to chime in or has any other thoughts.
Dawn, that was an incredible response. I know that I totally threw you, in terms of asking such a controversial type of question, but you answered it with such wisdom. And I really like that comment that you made, that there can be two truths, and that we, the past exists, and that nursing exists in such complexity. So I think it was incredibly wise. I'm not sure if anybody else has something else they wanted to mention or comment. Please do it in the chat. I can bring it up in the next round of questions. I'm just going to make another comment, and there's one more question, Dawn. So somebody's calling in from Spain, and they just made a comment in that the colonialist era attitudes and classism remains persistent there, and where the power relationships between health professionals and patients is still very paternalistic. That Laura had said, it's been a very interesting few years living there and accessing care without a full mastery of the language and in a foreign cultural context. So thank you, Laura, for that comment. I just wanted to make sure that Dawn heard your comment. And a question from Donna Jepson. So she had asked, some health authorities or hospitals in BC ask every client or patient if they are Indigenous at the admitting desk when they get to the hospital. Can you comment on this in terms of learning a person's cultural values based with the info you shared about the reluctance for some Indigenous people accessing care? Donna is wondering how this question feels at the admitting desk.
Yes. Oh my gosh. Another timely and very controversial step. So our Ministry of Health within British Columbia, as of we're just coming up on a year, I'm sharing that for context for folks coming from other provinces that may not have this implemented. But we have a now policy for self-ID, so required to ask if a patient identifies as Indigenous or not. And we are again in the growing pains, and I would say my reliable two truths exist wisdom that was shared with me always applies, right? That, I think folks are, so there's been quite a bit of resistance at times, especially in the rollout, because a whole bunch of important reasons, but one of them being that, are you putting an Indigenous patient on the spot, that they are, a lot of survivors say in their testimonies how, they are trying to just fly under the radar, create as little disruption as possible when accessing care, because they're so afraid of that power and or experiencing violence, right? And that's terrible. But that is the reality, and we have to also honor that that's how people feel safe. My mentor, Cheryl Ward, was talking about how her and her mom, every time that they go to access healthcare, and she even talked about it even in her just healthcare practice, was always dressed to the nines, right? Hair done, lipstick, makeup, earrings, deliberate, because they wanted to present as I'm lacking the word, but wanted to disrupt those negative stereotypes that they know that followed them as Indigenous, identifiable Indigenous women, and they had she'd reported stark differences when she'd made that connection to then how she presented if ever she was, taking her mom to the emergency room or to get care. So there is a piece of wanting to protect, or, for folks like me that can be white passing, again, to, I'm not I'm not saying this for myself, but would, you know, again, just rather not be identified for fear of harm. And while that may be true, we also, that movement was done with the intention of, from Indigenous-led advocacy regarding disaggregated data. So we have not had the data, and nursing was very complicit in this, right? So our colleges, even despite activists among, you know, Indigenous nursing, constantly putting pressure on the colleges to ask if Indigenous nurses to self ID, because we just don't have any idea of what the numbers are. And that also, you know, makes it really challenging to connect and mobilize and do advocacy work, right? And, you know, when these bigger, broader systems have that capacity to get that snapshot, it's critical. So the grandmother's report is a report that was done regarding the need for disaggregated data. So anyone within BC or any other provinces that are interested in this, that's a really good report to explain the framework as to why that's needed. Very Indigenous led by grandmothers and matriarchs. And I think it goes back to the principle that if we don't know what the problem is, then we cannot address it. And so when we're looking at health inequities and we're looking at anti-Indigenous racism, one of the shocks for BC when the In Plain Sight report came out was like, PCQO and PCLS and all of these complaint systems were like, well, we don't have any complaints of racism. How can racism exist? And yet 9,000 testimonies at 9,000 interviews had very clearly articulated that there is tremendous harm that exists and continues to exist. And so we also know that, you know, again, an important point for disaggregated data, you know, who's accessing care and how does race and racism impact that access or inaccess? Are folks are not willing to come in to access care? And if so, why is that? And what are you know, where are people coming from to access care? You know, in BC, you know, are we having, you know, so BC has a lot of Indigenous folks outside of British Columbia that also access that come to BC because of the weather and you know, a whole bunch of other reasons, but to access care. And so when we're looking at, you know, how we're tailoring services and who we're supporting, we have to know that through the data. And I think it's one of those two where some of that resistance comes from is that, you know, prevalent discourse in the 70s and 80s where, you know, I don't see race. And that still permeates a lot of everyone to this day. And we're in that process of dismantling it. But we know that that's not the case. We know now, again, from the research that bias and implicit bias exists. And the intention, again, from that was that, you know, we want to recognize that, you know, race is a social construct isn't real, and I don't want to treat anybody differently based on their skin color. That original intention was good, but unfortunately how that has kept and upheld systems is then this idea again that racism doesn't exist within society and that we don't have these biases and prejudices that work very subconsciously and are played out again within a healthcare system, and also that are embedded within systems and processes. So disaggregated, or that disaggregated data piece and that self-ID is, you know, it's not perfect, but we have to do something and we have to start somewhere. And this is the place that we've started. And I think there's ways to go about how we ask people, how we hold space for people, how we care for people within that process that can make it easier and better. And again, one of that key principle and educational aspect is cultural safety and how we're safe in our practice.
Thank you so much, Dawn. And I think that was the last question. And I told everybody I'd shared the quote on Twitter. I'm like, it's on it should be tagged by CHNC. But I think that I think a lot of people were interested in having a copy of that quote. But everybody will have a copy of the slides as well as the recording that will be posted on the CHNC website. So please go ahead, Dawn. Just look at the time. It's 1:10 p.m. Eastern time, and we're here till 2 p.m. Eastern time. So the next set of questions could be perhaps towards the end. Thank you
Great.
so much, Dawn.
Okay, thank you. So I think we've talked about it as well, but one of those things in how I think what holds us back at times that we have to take a deeper dive into looking at is within our broader nursing identity. So we talked about how, you know, within our nursing, we've been radical, we are advocates, we are in the know, we are at that point of care, we have that expertise, we have that heart-centered leadership, we have that knowledge base, and we have disrupted systems in many ways, including in terms of anti-Indigenous racism. We have been such a critical part of that movement. We have a colonial and ongoing legacy in a system where we are complicit. And, you know, there were times especially earlier in my career when I had just such an internal crisis of, you know, like how can I be complicit within a system and recognize that complicity, and also be dedicated to disrupting that harm, and how can I exist when those two are at conflict? Because just by being here, you know, I'm upholding some of those systems. And I contemplated opening a pie stand on the side of the road and living blissfully in, you know, not that tension. Very lucky to have some, you know, wiser nurses and mentors that guided me through that process to recognize that this is, you know, where I need to be. It's where I want to be. It's why we all show up for the work. And again, two truths can exist. One can be complicit within it and be working against it. And where we put our attentions and our care and our efforts is what matters. But within that too, that unpacking that I'm, you know, always engaged in, and of course will be till the day I die. But in my own nursing, just how what came up for me too, how much I bought into and enacted times that paternalistic, that saviorism that is so entrenched in nursing's way of being, that, you know, like, I think again, when we look at bias, there's these layered pieces related to nursing identity that we can often become blind to. And I know in my own reflexive practice, on the daily, how those things show up, and you know, I only hope I'm recognizing them as often as I hope to. And address them, and creating, you know, I think a call-in culture where we hold each other to account too. So again, broader nursing for us to look at that. So let's just look at the profession within some of these identities. But again, when I was talking earlier about, you know, those harms over there within the healthcare system, that arm's length, I think, is one of the key ways that we uphold that nursing identity. How can the most trusted profession, how can we that, you know, promote and embed care at every point in our practice, in our profession, in our standards, have contributed to harm? It's so oppositional and disruptive. And I think that's where too, like when I was using the example before about, some of the vitriol that came to some of my colleagues that wrote out about Florence Nightingale, I think that's where it comes from. That defensiveness is so real because it comes from a place of love, but fear, right? That, I don't want to be associated with that harm. But if we can't lean into where we're doing those, where our blind spots are, then again, then we're just blindly supporting that system. And, we, all of us who know from experience that fine line between, being in relationship, adding, your nursing expertise, and that knowledge is so critical, while also upholding that relationship and the patient as expert, or the people we serve also as experts in their own health. That often the system and the constraints that we work in, it doesn't often promote that. And that's when, again, we have this jargon of non-compliance and that superiority and that paternalistic and ways of being. And I think another key part, just again, broader speaking too, that nursing is challenged by is that in trying to gain credit within a system that we have also been oppressed within, that's also sometimes I think how that oppression then turns into, and particularly on ongoing ways. And I think that's very much, again, that biomedicine, right? Nursing has gotten, and again, this is so hard to hold space for these challenging conversations without it sound like I'm critiquing it, because there's elements of it, of course, that are really important and really great. But I remember from nursing school, because I was all about the relationship and care and all of that. And, I remember one of my profs at the time saying, you might want to dial some of that heart-centered care stuff back a bit, because, we lose, nursing kind of loses that, clinical critical, piece that we want to promote within nursing, again, to gain legitimacy within a bigger system that sees care as the fluffy stuff or the non-important piece, perhaps, I would say. And but then how that also then translates within how biomedical supremacy, white supremacy, and those notions then also get upheld within nursing, unintentionally or intentionally, I think. And we just have to be hyper vigilant of, those insidious ways of being that are actually counter the mission of the work, in disrupting anti-Indigenous racism and embedding cultural safety. And then in terms of individual, again, nursing identity, how this is the hard part. This is that rub and tension of recognizing, when those biases and prejudices show up in our own selves. And we don't hold a lot of space at times for our humanity, and also for how we have been constitutionalized within these systems. And that is sometimes, again, that harder work. And I think where that anger and defensiveness comes out, because we have to hold space that we all have personal bias that's going to play out in different ways. And it's one of those things too, the more we lean into it and look for it, then the more we see it. And just as one example that Donna shared this morning, just as we were setting up, was just around the word stakeholder, and how one of our colleagues had recognized its origins, and how problematic it is, within a colonial context as well, to identify that way and identify others that way. And then it brings up a whole bunch of other, notions around inclusion, and whose voice is represented and whose isn't at the table, and who's an add-on, and how that table is even structured, and it's a great reflexive piece, but has trickle out effects in so many different ways. And when you start again to notice these things, you start to also see it everywhere, and that's hard too. So I guess one of my recommendations too, in this really important critical collective work that we have to do, but also individual work that we do, that we hold each other with care and support and firm accountability, and those two things can exist at the same time. And I think that's the trouble, right? Like, and this is why the Florence Nightingale conversation is so important. Like, it divides people, and then it turns into like a right or wrong, instead of leaning into the learning and the context that surrounds it. That and that's the rich part. That's the space that we need to sit in, so that we all can just do better and be better as nursing. I love this quote so much. And I think, again, this is the spirit in which I, try to move this work forward, that we're not, blaming and shaming, right? Like, that's where people get off board, and we can have hard conversations. We can hold people accountable, because accountability is love. And it is my love for nursing and my care, and oh my gosh, on this glorious week of nursing, that we look at, take that deep reflexive dive into who we are. What do we need to work on? Where do we need to go? What do we need to stop? What do we need to just get rid of? And what do we need to carry forward? And how we do that together. I think that's where we need to focus our energies and conversations. And that, it's interesting, because I work in quality improvement as well, and in policy. And when we start having conversations around zero tolerance for anti-Indigenous racism, which is coming out, and I certainly think it's a important objective to have, but I'm like, also, what does that mean, right? What does zero tolerance mean? Does that mean from a punitive lens, like zero tolerance, like folks are like gonna get their license removed or fired? And not saying that there's not a time and a place for that too, but if we're gonna start really in a more intentional and fulsome way, start looking at addressing and how anti-Indigenous racism shows up and is embedded within society and the healthcare system, we will have no one left if we're going to have a firm zero tolerance. I mean, myself included. Like, I was raised within white settler society with my Irish Catholic influence, that was both, again, great and problematic all at the same time, in Montreal. And my education was very indoctrinating and held a lot of blind spots for me that I'm very grateful, actually, that nursing school helped help me unpack a lot of that. I'm so grateful to nursing. I'm grateful to my program at North Island College, and they were the only ones at the time, and are still one of the only schools of nursing that has an elder in residence. And I had so much support and love and care from Elder Dr. Evelyn Voyager, who held all of us with so much grace and support in our unlearning as much as our learning. I would say there was more unlearning than anything, and how critical that is. And so we can I mean, again, if this isn't in the realm of nursing, I don't know what is, right? How do we hold people accountable in these spaces with care and love, where we're inviting people in and not, silencing people in fear and rigidity and it getting buried, right? Like, that's not how we're gonna move this work forward in important ways. And then back to that TRC piece, that's what the elders and the advocates wanted. Again, not to, sit in that shame or anything, but really in order to address the issues. And I think actually on that note, my next slide, yes. I can't see what the next slide is. But so this is Elder Jerry Ullman, and he is our elder in residence for the health authority, so for the provincial health authority, and works with the Indigenous health team. And I'm just so grateful for his teaching. So I'll share two that I think are really important. So I had actually, no, I'm going to pause that one. So Jerry says, you can't say goodbye to a problem before you first say hello. And that, I think, really is the spirit of that truth piece. And I think, again, sometimes a more colonial mind frame, and I know from, my Irish Catholic upbringings, shame's my default always. And again, not discrediting all the really, beautiful, rich parts about my ancestry and that, but immediately I go to a place of, despair and shame at times. And again, leaning into nurses' truth and our own individual truth is only about healing and growth, right? This is about saying hello to the problem so that we can let it go and we can move on and we can heal from it and we can work together in relationship. And I say that again as individuals, but also nation to nation, Canada to sovereign Indigenous nations, and nursing within a colonial system. So again, as a guiding principle and practice, this always guides my work. Must say hello to a problem before we must first say hello to a problem before we could say goodbye. And then the other piece that I thought was such a beautiful lesson that Elder Jerry shared with me as I cried, kind of supported, mentored me, but I was working in direct care, which I loved, but similarly, I think, to a lot of Indigenous nurses, and even the example of Dr. Ramsden, where I was seeing so much racism and harm in direct care, and I wanted to be very strategic in how to disrupt that, and I knew that I needed to go into different spaces to be able to affect that change. So I had moved into policy work, but I also was really passionate about education as well. And I had an opportunity to work with the Sonia's team with our Provincial Health Services Authority. And the Sonia's team, for those who don't know, is our Indigenous cultural safety training that was mandated by the province 10 years ago. It has, morphed and grown since then, but it was to create a foundational baseline and really bridge the gaps in as I'd said, that settler colonial narrative that most of us that grew up in settler society just was not aware of Indian hospitals, or the gravity and the enormity of residential schools and forced sterilization, all of those pieces, right? So it's helping to bring healthcare providers, up to speed and at a foundational place. And obviously, it's just the beginning of the learning, but and it's done online and it's facilitated by facilitators, which also I think is such a great part of that learning, because you get to interact and you get to hold space for that collective learning that we're all doing and learn from each other and move and grow as the training progresses. So I had started with the team, and I was really trepidatious about moving into not only now non-clinical role, but a role that wasn't really specific to nursing, right? I mean, I think it is, and I can articulate it. And again, I could go on so many rants about how nursing, is again, leads the work for Indigenous cultural safety education, training, all of our roots, but other people don't know that, right? So I just felt, a heavy burden that I was moving into this team where it was only myself and one other nurse and a whole bunch of folks from different social sectors, because we also do training for education and justice and law and in those areas. But I knew it was going to be tremendous learning for me, because I was also going to be able to learn, well, one, from some of the leading scholars on Indigenous cultural safety and anti-racism work, but also in an Indigenous led team, and one of the only at the time that was really strong within the province, because this was quite a few years ago. And that I would be able to learn also from all of these different disciplines, and also bring my nursing, learning, their knowledge as well. So really exciting. But I just had this moment. I was so full of fear that, like, what does this mean for my nursing? Because my nursing identity is so important to me. And I wanted to keep nursing just at the forefront of my work. And I can't remember what was said, but me being emotional as per usual, I had said, we were doing like a closing after our training week, and I just got teary-eyed and thanked everybody for their support, and said, this week has been really hard because it's been on my mind that, not sure if I wasn't sure if I'd made the right decision to join this team and be so far removed from nursing. And Elder Jerry, of course, let me finish, and then said, oh, you are 100% where you need to be, because racism needs to be healed. And from my understanding and experiences, nurses are the greatest healers. And your work in this work is to heal racism, to heal that systemic racism, and bring that nursing knowledge to that healing process. And he said, you and your profession are such a gift to anti-racism work. Because of your healing knowledge as healers. And that was like everything to me as well, right? Like, and I think that I leave that with everybody without going on and rambling anymore, but that again, when I think of Dr. Ramsden's original intentions for how nursing carries this work forward, I think that Elder Jerry articulates that so beautifully, that our generation, this iteration, where we are now, is to heal racism. And again, as Jerry would say, Elder Jerry would say, we have to say hello to the problem before we can say goodbye. And that is our work now. So with that, I will open it up for more conversation, questions. And are people able to talk, or is it only through the chat? I'm sure this has been said to me, and I've missed this piece.
I'm able to unmute people, and if they would like to ask anything, and then what you could do is just raise your hand. There is a reaction button that if you push the reaction button, it's a smiley face at the bottom of the screen. And if you push on there, there is a raise hand. And if you raise your hand, I'll be able to see you, and then you'll be able to ask your question rather than putting it in the chat. So let me just check the chat again. There comments about that the work that you're doing, Dawn, is so great, and thank you for sharing your knowledge to help us in our work to unpack our thoughts and experiences and grow as disruptors and to heal racism. And there aren't any, another comment, I love the voicing about the duality of science and service and how we socialize nursing students to the valuing of both. One question from Patricia is, I'm curious how Dawn stayed true to herself when her humanity gifts and her practice were devalued because of the system agenda.
Yeah, that's a great question. And I think certainly, you know, Indigenous nursing mentors supported me in that, but I'm thinking of actually one of my first nursing instructors that was also very like justice orientated and mindful. And, you know, she had said she was saying this broadly for nursing, but, you know, the only way through in the hard moments, right, is to surround yourself with a group of nurses that, you know, you love and care and can support each other and hold each other, you know, accountable and debrief and, you know, that have your back. And I took that very seriously and am very, you know, blessed and privileged to have a tremendous circle of folks that hold me up. That you know, we also often will meet regularly as a collective, but also to just build that muscle and that flexing of, you know, just to reach out to each other when times are hard. And we've gotten really good at that. And I think that's, you know, so supported my mental health and wellness over the years. And I have struggled at times there, that undoubtedly, and cannot sugarcoat that. And there's been times when I've seriously questioned whether I was going to stay in nursing, but I love it so much. And it again is that care, mentorship, and community of women in nursing. And actually, a lot of them are men too. So but the womanhood that you know, have held me up in those harder times has been critical.
Thank you, Dawn. And in terms of I don't think anybody is raising their hand to ask any questions, so don't be shy. Please feel free, and I can unmute you. And there was an article that was just posted by one of the participants today. It's by Adeline Falk Raphael, and that just published an article just recently for June 2023. And the title of the article is called "Considering the Bitter Rivalry Within the Context of European and Colonial History of Women Healers," and that it's worth reading. So that would be a very timely type of article, and ties in a lot of what you're talking about. So I'll be interested to see that.
Me too. Thanks for sharing.
Mm-hmm. And
Carrie has her hand up. Or sorry, Barbara. I'm not sure if you were gonna.
Oh, Carrie, yes. Okay, let me unmute Carrie.
Hi, Dawn. Thanks for that. So I work in nursing education, and so I was wondering if anyone actually here today knows of any nursing frameworks that have been indigenized in the educational institutions that teach nursing in Canada. Because at our institution, we have discussed it, but sort of ran into some roadblocks. And the other challenge that we're seeming to have in education is, you know, I've been to loads of different teaching opportunities that speak to indigenization, and many times, you know, offering someone the opportunity to speak their truth is so important in terms of the truth and reconciliation recommendations. However, how do we support our nurse educators to support that, not being trained counselors? So there's some concerns that, you know, those raw feelings come up, and, you know, do you have any thoughts on how best to support our nurse educators? I mean, we do have elders at our college. However, when these discussions come up, they're not in the classroom, right? Mm-hmm. And so I don't know if you have any thoughts on how best we could move forward with these pieces, right? Because the stuff that we've looked at so far, like you could do little piecemeal things, that speak to the spirit of indigenization, but really when we're looking at our program, it needs a whole overhaul. Right. And when you were talking about Florence Nightingale and stuff, that just came even to more light of how we need to change our framework.
Yeah, that's a great question. And I think, as nurses, I think again, just relating to our own identity, we wanna know how to solve the problem, and we want to get down to work, right?
Yeah.
And this is like my therapist would be like, oh, like constantly me. I get so frustrated, right? Because I'm so impatient in moving this work forward. But again, elder mentorship is constantly keeping me in line, where an elder just shared with me a couple of weeks ago. I think I was expressing my frustration within the broader system and the work. And there I hear what you're saying around the piecemeal piece. And that is necessary. Like there's immediate actions that we need to do, that we can all do. And then there's the long game work that's also a reality. And this isn't going to happen overnight. We have, hundreds of years of set practices and principles that we're in the process of dismantling. And that is, I think, an important way to frame it, at least for me, in order to stay sane in the work, in that I break it down into what are the immediate pieces that I can do, and then how am I also working on that long game work as well, and they happen simultaneously, and they have to also work collaboratively within that piece. And I think it goes back to that slide that I was talking to about educators play a super key role. We want this next generation of nursing to go into the workforce and better prepared to address these issues. And that's one piece of the puzzle, right? Like, what are the regulators doing? What is the union doing? What are associations doing for to hit up all of these different areas, and nursing also right now? And that has to all be being done together. So knowing what your wheelhouse is and how you can do that work is critical. And what are the goals that line up for the next few decades for us to do this work? So I think so recently there have been Indigenous nursing chairs that have been established, I don't think in every province, but in coupled throughout Canada. And I know the BC collective and the nurse research chairs that are working in BC are setting up in the beginning processes of setting up a indigenized nursing program. I know they're starting within grad school, and I know just because I'm wrapping up my graduate studies at UBC, and I was just approached from UBC as well, that they're in the process of starting to talk about how they want to set up again an Indigenous program specifically for Indigenous nursing. And I think it's the conversation that a lot of schools of nursing are happening, and everybody's at different stages. And I think looking, so again, how that work it happens at the same time, right? That yes, there's every institution has a lot of work to do, either reviewing curriculum, their pedagogy, their how they're supporting Indigenous nursing students, how they're recruiting Indigenous nursing students, how are they focusing on retention, how where are the gaps in the current even educational system and model that makes it so that we can't also keep there was an article posted or written just a couple of years ago, and it just keeps happening, where we also can't retain Indigenous well, nursing scholars, but scholars in general, because of, the violence and oppression within that system and how that works, a very colonial based system, right? So, what's your nursing program doing in looking at that long game and how that's going to take shape, and knowing that's going to take years of work. And I love that you're saying that there's elders for folks to access. You're bringing in guest speakers and embedding it to the best of your ability at that time. It just happens in tandem like that. That's just how we have to move the work forward right now.
Great. Thank you, Dawn. It's Karen Curry. I'm going to take over now. Hopefully everyone can hear me. We've got some great questions here as well. And there's one more great question here in the chat. And I think it speaks to a lot of us that are here on this call. We're here because we want to be open and learn. And we also recognize that, there's challenges. So a question in the chat from Rachel is, I was wondering if perhaps you could give us some suggestions on how authentically we can engage in collaboration as a white settler woman in a privileged position. Obviously working with, but perhaps, seeing that there's a need and maybe resources are short. How do we drive? Is it appropriate for us, our role in ensuring that there's those policies in place, whether it's in our workplace or our nursing school that we're working in, and with that focus on cultural safety. So how to kind of, again, I think you talked a little bit about that balancing, but just wondering your thoughts on that. If folks are seeing there's work to be done and maybe not the bodies or the right people and want to do something.
That is such an important question that I think it's when we look at that reflexive piece that each of us needs to ask and how we move this work forward. So a few ways to support that work, but so even for myself, that there's a reason why protocols and Indigenous ways of knowing is to look at who you are, know where you came from, and how you carry that work forward. And that's individual work for each of us to do, based on our own identities. But for myself, there's a lot of disruption to my family and my grandmother in terms of our indigeneity, and very common at times, especially East Coast, and being of Mi'kmaq ancestry. We're the longest colonized peoples, and the era in which she was born and lived in, there was just a lot of, legislation and socio-political, violence and disruption that impacted how our family didn't even know about our indigeneity for a really long time. So, and as I said, my grandfather, who was Irish Catholic white immigrant, that's how we were raised in Montreal, and with a lot of, Irish French pride. So for myself, and this is not like anybody told me I could or couldn't, how I take up space or don't take up space. This is just for me, right? For my own reflection, and that is an ongoing journey. And I'm in a reclamation process within my own identity, for my family, for my children, for my son, and for those upcoming generations. And so my answer today might be different tomorrow, but just to share how vulnerable and individual this work is, I stay very much within an anti-racism lane. Like, I again grew up with all the privilege of white settler society. I am white identifying, and I did not grow up in culture. So there's folks on my team that have and did, and I see it as my responsibility to address those harms. And that's where I focus my wheelhouse, is kind of paving the work and the road forward to support those Indigenous knowledge keepers and matriarchs, and and upholding and to account the system regarding those rights. So that's again just my own individual work and how I've done that. But this comes up a lot with a lot of my colleagues that solely identify as a white settler. And the Sonia's team taught me a lot about that. We did a lot of caucus work in terms of our racial identities as settlers of color within the system, white settlers, and for those of us that are Indigenous or mixed Indigenous, and again, how all of that complexity plays out and how we support each other in that work and hold each other again in loving accountability to say, oh, that's that playing out right now. Let's pause and look at what's coming in that. And then two, how we facilitate teams to be able to identify that within themselves either. And that we Darcy Rosalie is a white settler on our team right now, and she's been doing this work for a long time, and she faces a lot of criticism for being a white woman in this work. And, I fiercely defend her and as a learning opportunity too, right? And we had a lot of criticism even within the Sonia's team, like, why do I have a white facilitator, on this Indigenous cultural safety training? But the reality is, whose job is it to dismantle white supremacy? Is that the job of Indigenous people?
Karen, I think you're muted.
No, I just lost connection. I'm sorry. I'm sorry there. I'm not sure what's going on there.
Are you still there, Dawn?
I think we lost Dawn, didn't we?
Oh, there must have been some type. I'm sure Dawn will come back on again. There must have been something that happened.
Yeah, there was a break in the connection. I thought maybe it was just my end, but maybe it happened to other folks as well.
I know that Donna has a few things to say at the very end, so if people could just please stay on for a moment. Yeah, great, Dawn.
there's Dawn.
Back in. Wonderful. So Dawn, we're not sure what happened exactly there with the connection.
Dawn, can you hear us?
You might be sending us a message right now, I think.
Oh, Dawn is jumping back on, but she doesn't think the mic will work.
Okay.
And battery died on the mic while it was plugged into the monitor. So
Oh dear.
Yeah. But Karen, if you wanted to thank Dawn anyway.
Yes, indeed. We are coming up to that time. Dawn, so sorry that the technology, but we've had almost up to 80 participants here today. And if your screen does come back on, some final closing thoughts, we really appreciate it. But our hearts are filled with a lot of gratitude for you joining this Nurses Week to bring your knowledge, your learning, and your passion to share this with community health nurses and other nurses. We are all here because we recognize we need to learn. We want to be part of the work. We want to be disruptors. I think community health nurses are disruptors at heart. And we want to have the evidence and information that we need to do the work, no matter where our community or profession brings us, or our personality or families, wherever we find a need to help. I think we need to do that.
I'll put you on speaker and so hopefully you can hear.
Yeah, can you hear me, Dawn? I'm just saying we're really grateful for your work, and thank you so much for sharing of your time and your passion with us as we take this out into the world and we reflect and do the work. And I really liked where you said, and I recall some of our CHNC conferences, we've had connections and had Indigenous presentations, and Jerry Oldman was at one of our conferences, and I had the privilege of sitting at the table and having tea with him and introducing him. And he was just a wonderful force of sharing his journey, and it was wonderful to do that. So we've had some great sharings and learnings at our conferences that we're building on. But I remember someone saying, and it really hit me and struck me, that the work of reconciliation is for the white settlers, that it's our turn to understand and know the truth and move forward. So thank you for giving us some information and some good, amazing quotes for us to share in our workplaces and with our students. So thank you very much. So I'll turn it over to Donna for some final closing on this Nurses Week. We've got some great stuff going on in CHNC.
Great. So one of the things that we do have is the book called Caring and Connecting. It's currently 50% off during Nurses Week, and I know that a few nurses have ordered that book already. Some professors are reading stories at the beginning of their class to their students, and I've also heard of nurses in meetings, community health nurses, reading a story during their team meeting. So that's a great buy. And then, Barb, do you want me to speak to the next webinar coming up, or do you want to speak to it?
Go ahead, Donna.
Okay, so the next webinar is coming up probably in a couple of weeks on Tuesday, May 23rd. It will be 1 hour in length, so shorter than the sessions that Dawn has provided to us. The session will be 12 to 1 Eastern time. And the speaker is Dr. Nancy Durand, an associate professor at U of T. And the topic is It's Time to Talk, Increasing HPV Awareness and Prevention with Your Patients. So, and that was sponsored by Merck, Sanofi, and Pfizer. So I think that brings us to the end of this webinar series. Thank you, Karen, for thanking Dawn, and for everyone on our board for supporting and helping us be able to have this event. And a special thanks to Anthony Lombardo, our executive director, for helping with the registration process, and Lennox for sending out links and helping us with the promotion. So please join us again for the next session on Tuesday, May 23rd. And there will be more webinars right into 2024. And we're hoping to have a face-to-face conference sometime in 2024, hoping May or June. So thanks again to I counted over 109 people at one point for attending today. Bye for now.
Thank you.